guys, welcome to another lecture and welcome to my channel. Today we'll be discussing something about the JDM, Juvenile Dermatomyositis in pediatric population. Before I begin, I would like to request you to like, share, subscribe to the channel if you haven't already, and please check out my website. It is, all the free videos are also there, or you can download our app from the Play Store or App Store. So all the links are in the description below. So JDM, juvenile dermatomyositis, is a very common, uncommon, muscle autoimmune disease, but it is more commonly seen in pediatric population, and the peak age of onset is 7 years with high female preponderance. Okay, there is also presence of seasonal variation, and obviously there might be some cross reactivity with viruses. So seasonal variations are there. So that is the two things that you need to understand. Now, JDM, what are the clinical findings of JDM? So you have to understand that JDM stands for juvenile dermatomyositis. So two systems are involved: skin, dermato, and myositis, muscles. So for myositis, what do you have? You have weakness, muscle weakness, that is predominantly proximal muscle weakness. Proximal muscle weakness is including the involvement of shoulder girdle, and the shoulder girdle movement abnormality is hallmark, or historically been tested by the ability to comb hair like this, okay, or moving the arm above the ground. So that is what it usually begins with, weakening. Okay. And there are some cutaneous finding, but usually these patients have a insidious and a insidious and progressive abnormality. It begins and it progresses. Okay, so this weakness that is there, they can persist during climbing of stairs. One of the hallmark sign that we see is that in children who are usually more than 3 years old, they can get up from a supine position, like like the undertaker wakes up in the WWE, waking up from a supine position. It is possible for most children who are more than 3 years. Yet in patients with juvenile dermatomyositis, they will first turn prone, and then they will with the support of the hands and feet, they will get up. So they cannot get up directly from the supine position. So that is one of the hint that the patient might be suffering from muscle weakness. There might be palatal or cricopharyngeal involvement, and nasal twang might be seen. Silent aspiration is also very, very common. Grover's sign is very commonly seen in patients of JDM, and it is a very good screening test for these patients. Okay, so what are the other historic or the the specific clinical features that we see with JDM? So first is the heliotrope rash. Now, what is the heliotrope rash? So for heliotrope rash, they are a purple, violet, or a lilac colored erythematous patch. Erythematous periorbital patch or rash. Periorbital rash or a patch. So this is what a heliotrope rash is. It is seen around the eyes, and it is associated with periorbital edema. Okay. Next are the Gauthron's papules. So what are Gauthron's papules? They are violaceous patches. Again, violet color, violaceous patches over extensor surfaces of the joint. Okay. Then the next finding is the Gauthron's sign. Okay, Gauthron's sign. Now, Gauthron's sign are actually the Gauthron's papules, which are non-palpable. Non-palpable papules. Papule which is non-palpable is known as Gauthron's sign, which are non-palpable. Okay. Then next is malar or facial erythema. Then there might be something known as shawl sign. Shawl sign, what do you have? This erythema is over the shawl-like distribution. So this shawl sign might be seen upper back, posterior neck and shoulder is involved. There is erythema. Shawl sign is a erythema. Then there is V sign. What is V sign? In the V-shaped T-shirt shaped V area, you have the erythema. So it is something like a shawl sign. Third is the holster sign. What is holster sign? So this erythema is on thigh and hips. Erythema on outer surface of thigh and hips. Okay, so it is a holster sign. There might be erythroderma in the sun exposed area, or there might be associated livedo reticularis, or there might be presence of cutaneous ulceration, or there might be presence of mechanics hands. There is fissuring, cracking of the or there might be presence of hyperkeratosis or scaling in the areas where the IIM, the distal in the metacarpophalangeal joint. Usually those are the involved areas, that is known as mechanics hands. There might be paniculitis, oeculoderma, calcinosis, and alopecia, lipodystrophy. So all these are the features of the patient with juvenile dermatomyositis. The diagnostic criteria, the criteria of the diagnosis of JDM is known as Bowen-Peters criteria, and in which usually the patients have the muscle and the skin involvement. Okay, now no specific test is negative, but you see myopathy. You see myopathy on the EMG examination. But then again, it is not as specific because other causes also might be seen with the EMG abnormality. There is also increase in LFT, liver function tests are increased, and ANA is positive, anti-nuclear antibody is positive in 70% of the patients, 70% of the patients, but it is not specific. There are other antibodies, BSDNA, all that also might be positive, like anti-TIF, TNF alpha, all that will be also increased, but the highest prevalence of antibody is ANA. Treatment: high-dose corticosteroids and methotrexate. Corticosteroids and methotrexate are the drug of choice. This was something brief about JDM. I hope you like the video, and I will see you in the next one.